This presentation is about drugs for pain. We'll first talk about local anesthetics. In talking about local anesthetics, we'll first learn the basic pharmacology of these anesthetics, and there's two classifications. Local anesthetics are either esters or amides. The ester type anesthetics, which is represented by the procaine, we typically know this as Novocaine. This contains an ester linkage in their structure. However, the amide type agents, represented by lidocaine, or otherwise known as xylocaine, contains an amide linkage. The ester type agents and the amide type agents, they differ in two important ways. The first one is the overall method of inactivation and the promotion of the allergic responses. Local anesthetics stop axonal conduction by blocking sodium channels in the axonal membrane. So think about the propagation of the action potential. This requires the movement of sodium ions from inside the axon to now inside the axon. And this influx takes place through specialized sodium channels. But by blocking axonal sodium channels, the local anesthetic will prevent sodium entry, and thereby it's going to block the overall conduction. Local anesthetics are non-selective modifiers of neuronal function. What this means is they're going to block the action potentials in all the neurons to which they have access to. And the only way to achieve selectivity is by delivering the anesthetic only to a very localized and limited area. Now, although local anesthetics can block the traffic in all the neurons, the blockade develops more rapidly in some neurons than it's going to in other neurons. For example, in small non-myelinated neurons, these are going to be blocked more rapidly than the large myelinated neurons. Because of this differential in sensitivity, some sensations are blocked sooner than others. For instance, the perception of pain is going to be lost first, and then the perception of cold, warmth, touch, and deep pressure. The effects of local anesthetics are not limited to just your sensory neurons. These drugs also block conduction in the motor neurons as well. You can see with this table a side-by-side contrast between the ester and the amide local anesthetics. And I just want you to focus on where it says incidence of allergic reactions. The amide type anesthetics have a very low incidence, where the ester type anesthetics have just a low incidence. What's important to know about local anesthesia is the time course. Ideally, your local anesthesia would begin right away, and it's going to persist no longer or no shorter than you actually need it. But unfortunately, the onset of anesthesia is usually rapid. However, it's not always ideal. In some cases, anesthesia persists longer than you need it. In other cases, you're going to have to repeat the administration in order to maintain the level of anesthesia that's required to meet that sufficient duration. So what determines the onset of local anesthesia? Well, it's largely due to the molecular molecules of the anesthetic itself. And so before anesthesia can actually occur, the anesthetic must diffuse from its site of administration to where the site of action is going to be. And this is within the axon membrane. The anesthesia is going to be delayed until this movement has occurred. And the ability of the anesthetic to penetrate the axon membrane is determined by three things. The first property is molecular size. The second one is lipid solubility. And the last one is the degree of ionization at the tissue pH. Now, anesthetics of small size and high lipid solubility and low ionization actually cross the ion membrane more rapidly. I'm going to say that one more time. The anesthetics that are smaller in size with high lipid solubility and low ionization will actually cross the membrane more quickly. So in contrast, anesthetics that are larger in size with low lipid solubility and high ionization, those anesthetics are going to cross the axon membrane slower. Now, obviously, anesthetics that penetrate the axon more rapidly are going to have the fastest onset. So now we're going to discuss the termination of local anesthesia. This occurs as molecules of the anesthetic will actually diffuse out of the neurons and are carried away in the blood. The same factors that determine the onset of anesthesia, remember the factors: molecular size, lipid solubility, and the degree of ionization. This is also going to determine the duration of the anesthesia. So in addition to that regional blood flow, this is going to be an important determinant of how long the anesthesia will actually last. So where there's areas in your body with a lot of blood flow, high blood flow, the anesthetic is going to be carried away more quickly, and it's going to affect how it terminates. In regions where blood flow is lower, anesthesia is going to be prolonged. It's pretty common in practice that we will use a local anesthetic with the vasoconstrictor because there are some benefits. Vasoconstrictors like epinephrine will decrease the local blood flow, so this is going to delay systemic absorption of that anesthetic. So why is delaying absorption good? Well, it prolongs anesthesia and it reduces the risk of toxicity. Because the absorption is slowed, there's going to be less anesthetic used, and so you find a more favorable balance established between the rate of entry into circulation and the rate of its conversion into inactive metabolites. We should think about, though, that the absorption of vasoconstrictor itself can also result in systemic toxicity, and things that you might see are palpitations, tachycardia, nervousness, and hypertension. However, if you find yourself in this situation, if an adrenergic stimulation from absorption of epinephrine is too excessive, we can control these symptoms by providing an alpha or beta adrenergic antagonist. There are some adverse effects that we need to think about as well. Some of the adverse effects happen locally and some more distally. The local effects are a little bit less common. The first adverse effect is, we'll talk about how the effect of anesthetics can be on the central nervous system. And so when absorbed in sufficient amounts, the anesthetic can actually cause first an excitability followed by depression of the CNS. In the first phase, the excitation phase, you may actually develop a seizure and may have to manage the seizure with IV benzodiazepine like diazepam or midazolam. However, you can get into the depressant phase as well. And this phase can range from drowsiness to unconsciousness, and even if not corrected on time, it can lead to coma. Death can also occur secondary to respiratory depression. And if this respiratory depression is too prominent, then your patient may require mechanical ventilation. Local anesthetics also can have an adverse effect on the cardiovascular system. In sufficient amounts, local anesthetic can affect the heart and the blood vessels, and these drugs can actually suppress the excitability in the myocardium and the conducting system. When these two things are suppressed, then you can have bradycardia, heart block, reduced contractile force, and this can even eventually lead to cardiac arrest. So what happens to your blood vessels with local anesthetics? They actually relax the vascular smooth muscle, which is going to result in vasodilation that's going to cause a reduction in blood pressure or hypotension. There's a gamut of hypersensitivity reactions that can occur as well. And this can range from something as small as allergic dermatitis to anaphylactic shock, and it can be triggered by a local anesthetic. Now, we know that these reactions are pretty uncommon, and even though they're uncommon, they're much more likely to happen with the ester type anesthetics, so the Procaine. A lot less likely than with the lidocaine or the amides. And if you have a patient that is allergic to an ester type anesthetic, it's fortunate because cross hypersensitivity between esters and amides, we don't really see that in clinic or in clinical observation. So we can actually use an amide anesthetic if we know that our patient is allergic to an ester anesthetic. Because they are unlikely to cause hypersensitivity reactions, the amide type anesthetics actually have largely replaced the ester type agents, especially when administering, if you need to administer something by injection, you're going to see more of the amide anesthetics out there. The last adverse effect that we're going to talk about is methymoglobulinemia. And the one anesthetic that typically causes this is the topical benzocaine. This is a blood disorder where your hemoglobin is going to be modified to a state that it can't release the oxygen necessary to the tissues. And so if your hemoglobin is converted to methymogloblin, death is going to result. Methymoglobulinemia has been associated with not only the topicals, but benzocaine liquids, sprays, and gels. Most of the adverse effects actually have occurred with children 2 years or younger. And the reason why these children were being treated was that they were getting the benzocaine gel for teething pain. And so because of this risk, when you're thinking about prescribing topical benzocaine, you have to avoid prescribing to children younger than 2 years old unless you are going to monitor, and it has to be used very cautiously. You also, in any case, even if they're older than 2 or they're an adult, you're going to monitor when you apply it to the mucous membranes of the mouth, you're just going to be very cautious to see what happens. So we're going to look in more detail now the individual properties of Procaine and lidocaine. So Procaine, remember, is the ester type local anesthetic. It's not effective topically. So when you are using Procaine, you're giving it by injection. Administering it with epinephrine, again, is going to delay absorption. And even though it can be readily absorbed, you're watching out for systemic toxicity, but it's rare. It's rare because the plasma esterases are going to rapidly convert the drug to an inactive, non-toxic product. Procaine poses a greater risk for allergic reaction than the amide type anesthetics. So this should all be sounding familiar because it's a review of the last few slides. Lidocaine is a prototype of an amide type agent, and actually it was introduced in healthcare in 1948. It's the most widely used local anesthetic, and it can be administered topically or by injection. Now, anesthesia with lidocaine is more rapid and more intense, and it's going to be more prolonged than if you were to give it with Procaine. Effects can be extended by now co-administering epinephrine, and it's favored because allergic reactions are very, very rare. And again, if you have a patient that's allergic to ester type anesthesias, then you can use the amide type, which is the lidocaine. However, if the plasma levels of lidocaine get too high, this is when you can see CNS and cardiovascular toxicity. Um, the last thing that we're going to talk about here is cocaine. Now, cocaine was our first local anesthetic, and it's an ester type anesthetic. If you administer it topically, you can use it for anesthesia of the ear, the nose, and the throat. Anesthesia develops pretty rapidly, and it's going to have an effect for about an hour. But not like the other anesthetics. Cocaine actually causes intense vasoconstriction because it's blocking the norepinephrine uptake at the sympathetic nerve terminals. And this is especially going to be useful in the treatment of expistasis. Now, according to the drug itself, it should not be given in combination with epinephrine or any other vasoconstrictor. Let's say that one more time. You can't use this product in combination with epinephrine or any other vasoconstrictor. In addition, cocaine has pronounced effects on the sympathetic and the CNS. And the sympathetic and CNS effects are largely due because they are blocking the reuptake of norepinephrine by adrenergic neurons. So let's look at the clinical use of these local anesthetics themselves. And we know that they can be administered topically as surface anesthesia and by injection. So for infiltration anesthesia, nerve block, intravenous, regional anesthesia, we use it in epidural form, and spinal anesthesia. The uses and hazards of these anesthesia techniques are going to be discussed now. So first we're going to talk about topical administration of anesthesia. And this is when you apply anesthesia directly to the skin or to a mucous membrane. And the agents that are common are lidocaine, tetracaine, and cocaine. So why would we use this? When we apply local anesthesia to the skin to relieve pain, we can also relieve itching, soreness in various areas. You think about a lidocaine patch for like a backache. We can also use it for infection, thermal burns, sunburn, diaper rash, wounds, bruises, abrasions. Think about poisonous reactions by plants and even insect bites. You can also use it by applying it to the mucous membranes of your nose, your mouth, even deeper in your throat, your pharynx, your larynx, the trachea, the bronchi. We have local anesthetics for the vagina, the urethra. Sometimes we use an anesthetic like a lidocaine before putting in a catheter. We can also use local anesthetics to relieve discomfort that's associated with hemorrhoids, anal fissures, and pruritus ani. But when we do this, we have to think about the systemic risk for toxicity. When we apply it to the skin, it can be absorbed in sufficient amounts that can cause serious or even life-threatening effects. Cardiac toxicity, so you might have a patient that if absorbed too much of the anesthetic can lead to bradycardia, heart block, even cardiac arrest. Again, with the CNS toxicity, remember we talked about seizures, but also respiratory depression and even coma. Obviously, there's going to be a risk for toxicity that's going to increase the more and more that the patient is absorbing. So how much is the patient going to absorb? This is primarily determined by, number one, the amount that was applied, 2, the skin condition, and 3, the skin temperature. So to minimize the amount absorbed, we're going to also minimize the risk. So this is what you're going to teach your patient. Apply the smallest amount needed. Avoid application to large areas. Avoid application to any areas of irritated skin, broken skin. You want to avoid any strenuous exercise. You don't want to wrap the site. You don't want to heat the area. This can all accelerate the absorption because it's going to increase the skin temperature. Now we'll talk about the administration by injection. So this carries significant risk, and it really requires a very special skill because it can cause adverse reactions. And when you are using anesthetics by injection, it's usually going to be performed by an anesthesiologist or someone that has been specifically trained to provide this type of intervention. Because severe systemic reactions can occur, you have to have equipment for resuscitation that's immediately available. You have to have an IV line just in case you need it. There could be a situation where rapid treatment is going to be necessary because of toxicity. So you need to have that IV line ready. Some things you need to think about is inadvertent injection into an artery or vein. It's going to cause severe toxicity. You have to ensure that the needle itself is not in a blood vessel when you do it. So you want to aspirate before you actually inject to ensure this. After the administration of the anesthetic, you have to monitor the patient for their cardiovascular status, their respiratory status, and their consciousness. So, to reduce the risk of toxicity, you want to make sure that the local anesthetic that you're using is being administered in the lowest effective dose. I'm going to talk to you about infiltration anesthesia and then nerve block anesthesia. Infiltration anesthesia, this is achieved when you inject the local anesthesia directly into the area of surgery or the area that you're going to manipulate. It can be prolonged by combining the anesthetic with epinephrine. You can use this in infiltration anesthesia. The most common agents that are used are lidocaine and bupivacaine. For nerve block anesthesia, this is achieved by injecting a local anesthetic right into the area or near the nerves that are going to supply that surgical field, but at a site that's distant from the actual surgical field itself. This technique is the advantage of producing anesthesia with doses that are even smaller than those needed if you want to go in for infiltration anesthesia. So what drugs might you use to achieve this? Lidocaine is a pretty common one used to achieve this. And your drug selection is really based on the required duration of the anesthesia. So lidocaine is a good one for shorter procedures, but if you're going to have a longer procedure, you might want to use bupivacaine. Now, an example of when someone might use a nerve block is if they are, let's say, working on your teeth. Some of aesthetic dermatology and aesthetic medicine techniques are done using nerve blocks. You think about fillers. This is a situation where you can use a nerve block to successfully suspend the pain. We're going to move on and talk about the opioid analgesics, antagonists, and the non-opioid centrally acting analgesics. What is a pure opioid agonist? The pure agonist will actually activate the mu receptors and the kappa receptors. When it does this, the pure agonist can actually produce analgesia, euphoria, sedation, and respiratory depression, can also cause physical dependence, constipation, and other effects as well. The pure agonist can be divided into two different groups: the strong opioid agonist and the moderate to strong opioid agonist. Let's talk about morphine. This is a prototype of the strong agonist. Codeine is a prototype of a moderate to strong agonist. We're going to talk about the agonist-antagonist opioids. There are 4. Pentazocine, nalbuphine, butorphanol, and buprenorphine. The actions of these drugs at the mu and the kappa receptors, you can actually see them here in this diagram. When they're administered alone, an agonist-antagonist can produce analgesia, but if we give it to a patient who's already taking a pure opioid agonist, the drugs can actually antagonize analgesia caused by the pure agonist. Pentazocine is a prototype of an agonist-antagonist. Last is the pure opioid antagonist. The pure opioid antagonist acts as an antagonist at both the mu and the kappa receptors, and these drugs don't produce analgesia or any effect caused by opioid agonists. Their principal use is the reversal of respiratory and CNS depression that can be caused when we overdose with opioid agonists. So again, it's a reversal of the opioid agonist. One of these drugs, methylnaltrexone, is used to treat opioid-induced constipation. A familiar drug is naloxone or Narcan. This is a prototype of a pure opioid antagonist. When prescribing opioids, we need to think about the adverse effects. The most serious adverse effect is respiratory depression, and at equal analgesic doses, all of the pure opioid agonists will depress the respiratory system in the same extent. And overdose and death actually is most commonly from respiratory arrest. The opioids will depress the respirations primarily through the activation of the mu receptors. And although there is some activation of the kappa receptors, it's actually mostly because of the mu receptors. Now, the time course of respiratory depression can begin up to 90 minutes after a PO dose, and with prolonged use of opioids, you begin to build a tolerance that develops to respiratory depression. There are some patients, think about the very young patients or the very elderly patients, and those that already have an underlying respiratory disease like asthma, emphysema. They're especially going to be sensitive to respiratory depression, so we have to really monitor these patients more closely. Outpatients should be informed always about the risk for respiratory depression when you're prescribing, and you want to make sure that you are writing out the instructions to notify, in your instructions you have them tell you and notify you as a prescriber if respiratory distress occurs. There are other adverse effects like constipation, orthostatic hypotension, urinary retention, emesis, sedation, neurotoxicity can also occur, tolerance, and also physical dependence. Those can be also within the realm of adverse effects. There are other strong opioid agonists that are available, and really pharmaceutical companies have tried to create newer opioid agonists because they wanted to try to find something with the same strength of analgesics but with the lower potential for respiratory depression and abuse. However, none of the newer pure opioid agonists can actually do this, and they aren't really considered superior to what we already have in morphine. These drugs are essentially equal to morphine with respect to their analgesic action, their abuse liability, and the ability to still cause respiratory depression. Also, they can cause sedation, euphoria, even constipation, urinary retention, cough suppression, hypotension, and meiosis. So despite their similarities to morphine, the newer drugs do have some unique qualities, however. One agent may be more desirable than another in a particular clinical setting. With the newer pure opioid agonist, toxicity can be reversed with an opioid antagonist, like Narcan. The differences between morphine and the newer strong opioid analgesics are going to be continually discussed, but I just wanted to show you these tables and diagrams here that show you the dosage, the routes, and the time courses for morphine in comparison to the newer agents that you can use. So first, we'll talk about fentanyl. Fentanyl is a strong opioid analgesic and it has a high milligram potency. So what that means is it is about 100 times stronger than morphine. 8 formulations are available right now, and you can administer fentanyl by 4 different routes: parenteral, transdermal, transmucosal, and even intranasal. Depending on how you give it or the route, it can be used for surgical analgesia, chronic pain control, and it can even be used for breakthrough pain in patients that are taking other opioids. They are all regulated under Schedule 2 of the Controlled Substance Act. So in order to prescribe, you do need a DEA license that allows you to prescribe under Schedule 2. Now, regardless of the route, fentanyl has the same adverse effects as the other opioids. We still have the respiratory depression. We still have to worry about sedation, constipation, urinary retention, and nausea. But of all of these concerns, respiratory depression is the greatest. You can also use Narcan to reverse if there's any signs of toxicity as well. Fentanyl is metabolized by the CYP3A4, which is an isoenzyme of cytochrome P450. So fentanyl levels can be increased by CYP3A4 inhibitors. So your patients that are taking these inhibitors have to be closely monitored for severe respiratory depression and other signs of toxicity if they are taking these inhibitors with fentanyl. Methadone has pharmacologic properties that are very similar to morphine. It's effective orally and has a long duration of action. You can give repeated doses, which can result in accumulation of the drug. Because methadone has a long half-life, it has the potential also to cause QT prolongation. You want to talk to a pain specialist to see if it's recommended when starting or titrating methadone in any patient. Methadone is used to relieve pain. It's also used to treat opioid addiction as well. Whenever you use methadone for pain control, again, you want to consult also with the pain specialist. The use of methadone for pain control has risen dramatically, and the use of methadone as a drug abuse treatment program we will discuss further later on when we go through chapter 35. Now, because methadone can cause this QT prolongation, you have to make sure that your patient gets an ECG before you start them on methadone, and then about a month later, 30 days, you want to check them again, and then every year after that. Now, if the QT interval exceeds 500 milliseconds, then you have to stop the methadone, or at least you have to reduce the dosage. But stopping methadone would probably be the better action at that point. In terms of hydromorphone, oxymorphone, and levorphanol, we have to understand the basic pharmacology. Now, all 3 of these drugs are strong opioid agonists. And again, they have a pharmacological action that's pretty close to morphine. They are all indicated for moderate to severe pain, and the dosages and time courses you can see shown on this table to help you to compare. Adverse effects really are similar. You have the respiratory depression, sedation, cough suppression, constipation, urinary retention, nausea, and vomiting. One thing to note though is that when you give hydromorphone, it does cause less nausea than patients that are getting morphine. You can also use Narcan to reverse the toxicity as well. And these 3 drugs are also Schedule 2. We're going to talk about the moderate to strong opioid agonists, remembering that these are very similar to morphine. They also will produce the same effects like analgesia, sedation, euphoria, but again, they're also causing respiratory depression, constipation, urinary retention, cough suppression, and meiosis. Okay, so keeping that in mind. So we are going to talk now about codeine, and codeine is indicated for relief of mild to moderate pain. We usually administer it by mouth, and the side effects are really dose limiting. So if you take codeine, it can produce a significant pain relief for the patient, but that degree of pain relief is usually achieved very low and much lower than that of morphine. And so when you take it in its usual analgesic dose, which is 30 milligrams, it's going to produce as much pain relief as taking about 325 milligrams of aspirin or a 325 milligram dose of acetaminophen. For analgesic use, codeine is formulated alone, and also you can get it formulated in combination with a non-opioid analgesic like aspirin and acetaminophen. Because codeine and non-opioid analgesics relieve pain by different mechanisms, the combination can actually produce a greater relief or synergistic effect that you can achieve, rather than using one alone. And so codeine is also classified under the Schedule 2 of the Controlled Substance Act. The combination, though, is classified under Schedule 3. So if you have codeine and Tylenol or codeine and aspirin, then that's going to be a Schedule 3 drug. The abuse liability of codeine is significantly lower than just that of morphine. It's also extremely effective as a cough suppressant, and so we use it pretty frequently in a clinical setting for this action. The antitussive dose of codeine would be 10 milligrams. It's very important that you understand that it's going to be lower than that analgesic dose of 30 milligrams. When you have this mixture of codeine in this antitussive dose, it's under a Schedule 5 drug. If you are going to use codeine, you want to consider the black box warning. So in the liver, about 10% of the codeine dose is going to convert to morphine. And so that's the active form of codeine. And the enzyme that's responsible for this is the CYP2D6, which is, again, an isoenzyme of the P450. Among the ultra-rapid metabolizers, which carry multiple copies of this enzyme gene, codeine is usually effective and has led to death in some children. Unusually effective. So we have severe toxicity that can develop in a woman. So if you say a woman is taking codeine, we've had some severe toxicity cases develop through breast milk. And so if you have a breastfed infant and the mom's taking codeine, there has been high levels of traces of morphine in the breast milk because of this really ultra rapid codeine metabolism that happens when codeine is broken down in the liver. Again, it metabolizes to morphine. Oxycodone, you might know it more commonly as Oxycontin. This also has an analgesic action that's pretty equivalent to codeine. We also give it orally. Oxycodone is available by itself, but you can also get it in a combination with another adjuvant drug as well. It is a Schedule 2 classified drug no matter what formulation you have. The black box warning of codeine is pretty fatal. You have a high potential for abuse and fatal respiratory depression. Long-acting forms of oxycodone should only be prescribed if the provider has had additional education regarding chronic pain and chronic pain management. So if you have a patient that you think oxycodone would be a good treatment for their pain, you might want to refer or consult with a pain management specialist. With hydrocodone, this is also a drug that has analgesic actions that are similar to codeine. It's taken orally to relieve pain. We can also take it to suppress cough. It comes in instant relief, 5 milligrams, but you can also get extended relief as well. And when you take the extended relief, you're usually taking it every 12 to 24 hours. It also can be combined with acetaminophen or ibuprofen and you can use it for cough suppression when it's combined actually with the antihistamine and a nasal congestant together. It's going to still be scheduled as a Schedule 2 drug. So if you're wondering, okay, what the trade name is of hydrocodone, or it sounds familiar, this is like Vicodin. In the hospital, sometimes we'll use Lortab as well. And so the black box warning for hydrocodone is that Vicodin is associated with hepatotoxicity. And the extended release forms of hydrocodone can actually, again, be fatal on the respiratory system. It can cause fatal respiratory distress. I'm going to wrap up my presentation today with the discussion of drugs for headache. Is a pretty common symptom that we're going to see in our practice, and it can be triggered by a variety of stimuli. Some people are very sensitive to stress, fatigue, acute illness, and even a sensitivity to alcohol can trigger different types of headaches. We are going to focus on treatment of severe forms of headache like migraine, cluster headaches, and tension type headaches. We know that the symptom headache itself can vary. Sometimes it can be as debilitating as you can't get up and move around, you can't function at work. It may cause photosensitivity and just a lot of pain. And these type of debilitating headaches are often unresponsive to the aspirin-like drugs that we typically will get over the counter. And when this is the case, the medical attention is merited. So when we try to treat headaches, we need to differentiate, of course, between the different types of headache and what the underlying cause may be. Is it a severe hypertensive headache? Is it because of hyperthyroidism? Maybe a tumor or infection? Disorders of the ears, eyes, nose, and throat are often a stimulus for a headache as well. And sometimes we have headaches that have no identifiable cause at all, like a migraine or a cluster headache. We are going to look on the next slide and to see what the different types of treatments are for the particular types of headaches. You can see using this chart that there is a limited amount of treatment for cluster headaches in comparison to that of migraine headaches, and some things you can use for both. One of the things that stands out to me is for cluster headaches, oxygen is something that can be used and effective, which we don't typically use for migraine. Sumatriptan is a medication that is great for cluster type headaches, but we can also use that triptan's class to help with migraines as well. So you can see that patient education and lifestyle modification is also warranted for both, but again, you do have a more extensive list for migraine treatment. For Prophylactic treatment you can use for cluster headache, Veramipil. You can also use corticosteroids and lithium, where for migraine headaches, the prophylactic medications that typically will be used is actually estrogen is a very common prophylactic that we will prescribe to help decrease the level of migraines. Migraine headaches are typically experienced with the female population, and so therefore you can use estrogen as a prophylaxis for that. NSAIDs, aspirin, naproxen, diclofenac, and other aspirin-like analgesic drugs can actually provide adequate relief in terms of migraine attacks that could be considered mild to moderate in symptoms. So when combined with metoclopramide, this can actually enhance the absorption itself. And so you can use it by itself or in combination. Aspirin also works well in combination with sumatriptan, which is a highly effective anti-migraine drug. And we can also use that for cluster headaches like you saw in the previous slide. This combination of aspirin plus metoclopramide, it costs less than sumatriptan, and so therefore it's something to consider when you are thinking about a first-line treatment. And actually, it causes fewer adverse effects. Acetaminophen should only be used in combination with other drugs. You don't really use acetaminophen alone for migraine. So one popular over-the-counter combination is Excedrin migraine, and this has acetaminophen, aspirin, and caffeine in it. Opioid analgesics are also considered treatments for headaches, severe migraines specifically, only if it's not responding to the first-line type medications that we've discussed. There is a potential for abuse, so we do want to regulate and limit the amount of opioid analgesics used for headaches. One recommended agent is actually using butorphanol, which is a nasal spray that you can order your patients. The triptans are a very effective class of drugs that are used for migraines. They are first-line drugs that can help terminate a migraine attack. And these drugs relieve the pain because they're able to constrict that intracranial blood vessel and suppress the release of the inflammatory neuropeptides that are causing the pain itself. In general, triptans are pretty well tolerated, and they rarely cause coronary vasospasms, which is an adverse reaction to taking triptans. Sumatriptan specifically is the first triptan that was available, and now it serves as the prototype for the group. Imitrex is a pretty common brand name of sumatriptan. You can give this drug by mouth. Also, there is nasal inhalation, and if you need to, it could be given sub-Q as well. It comes in a fixed dose combination with naproxen under the trade name Trexamet, and you might see this commonly used in primary care. Sumatriptan itself is taken to abort a ongoing migraine attack. It's not typically used if you're just starting to see some of the signs and symptoms. It's when it's on a full-blown attack and the other medications aren't working well. This is typically when I will prescribe sumatriptan or instruct my patient to use sumatriptan. It's also going to relieve headache type associated symptoms like nausea, neck pain, and the photophobia and phonophobia that will happen with patients undergoing a migraine attack. It does give complete relief to most patients, And you really will be able to see the benefit within about 15 minutes if you give a sub-Q injection. It takes about 30 minutes for intranasal and about 60 minutes after an oral dose or PO dose of sumatriptan. In patients that take sub-Q sumatriptan, 40 to 60% of those patients are going to have full relief within a couple hours. About 30 to 60% of patients that do the intranasal dosing will have the same effect in 2 hours. And only 18% of patients will have a full effect or relief of symptoms within 2 hours if they're taking a transdermal dose. And with the PO dose, about 50 to 60% of patients actually, it will take about 4 hours for them to get to complete relief. With oral or intranasal dosing of sumatriptan, we have to think about the bioavailability, which is pretty low. It's about 15%. In terms of the transdermal system, it's even lower, that's 6%. Whereas sub-Q dosing, because again, it's working faster, as you heard just recently, the bioavailability is actually pretty high at 97%. And so that's why oral and intranasal doses are considerably higher than your sub-Q and intradermal doses. It requires more to do the same job. Sumatriptan undergoes extensive hepatic metabolism and primarily by the monoamine oxidase, or the MAO, MAO. And then it's excreted in the urine. It also has a relative short half-life, about 2.5 hours. The adverse effects that you would look for with sumatriptan is sometimes patients will have this bad taste in the mouth just after administering it, but coronary vasospasm is the biggest concern. There is another option, but typically it's considered the second line option for those patients that have failed the triptans and they are not working. We can go to the ergot alkaloid. So ergotamine is a drug that we will typically go to if our patients aren't responding the way we hope with the triptan drug class. And we don't really understand fully the mechanism of action itself and how it will terminate a migraine. It does have complex actions that we believe the evidence is showing that the anti-migraine effects are related to agonist activities at the serotonin receptors. Additionally, there's evidence that show us that ergotamine can block inflammation associated with the trigeminal vascular system, and therefore we see the relief coming from the vascular effects in the cranial arteries. Ergotamine actually acts directly by constricting and reducing the amplitude of pulsations. So you can think about ergotamine. You want to think about this drug affecting the blood flow by depressing that vasomotor center. So I said that ergotamine is a second line drug, which it is. And the other reason why you might not want to use ergotamine, not just as a first line drug, but at all, is that there is a risk for dependence, and you never want to take ergotamine for long durations, or you don't want to take it daily as well. You can administer it orally, sublingually, and rectally. However, the bioavailability of a rectal administration is quite higher. And the half-life of ergotamine is only 2 hours, so that pharmacological effect can still actually be observed 24 hours after dosing. It is metabolized through the CYP3A4 enzyme, and it's followed by the excretion of bile. Now, most patients actually tolerate ergotamine pretty well. Um, However, sometimes it can stimulate the chemoreceptor trigger zone. And if you remember from pathophysiology, this trigger zone is what causes the symptoms of nausea and vomiting in about 10% of the patients. And so you can argue, whether you would want to give this medication at all because the migraine itself is already causing nausea and vomiting. But again, realizing that it only is affecting about 10% of the patients. If you use this drug, ergotamine, concurrently with metoclopramide, you can actually reduce the response. The other common side effects that you're looking for with ergotamine administration is weakness in the legs, numbness, tingling, overall myalgia, angina like pain, and tachycardia and bradycardia or bradycardia. Acute and chronic overdose can cause serious toxicity, and we call this ergotism. And in addition to the adverse effects seen with the therapeutic doses, an overdose can actually lead to secondary ischemia. And this is because the peripheral arteries and arterioles are constricting. Therefore, your extremities can become very cold and pale and numb. You'll start to have complaints about muscle pain and even gangrene if it's not stopped. Patients need to be informed of these risks, and they need to be informed so that they can look out for these types of signs and symptoms. If any of these things develop, it's a medical emergency and they need to be seen immediately. The risk for ergotism is highest in patients that have sepsis, underlying peripheral vascular disease, or they have a renal or hepatic impairment already. I just want to draw your attention to this table here that you can find in your text. And it's just showing more drugs to prevent for preventative therapy or prophylaxis. The B adrenergic blocking agents, propranolol, metoprolol. There are some anti-epileptic drugs as well, like Depakote or Tropamax, that can be used for preventative therapy. Some patients will be prescribed TCAs or tricyclic antidepressants. Elavil is a pretty common one that we'll dose right at bedtime. And again, we talked about briefly estrogen. And you want to give estrogen for those migraines that are associated with the menstrual cycle.